Thank you very much. It's really a pleasure to be here. I have never been to this meeting, but Gail has every year since I went to Toronto asked me to come, and I'm here, and I'm going to enjoy golf today and I plan to enjoy the meeting. So I'm going to today talk about bronchoscopic techniques in general for lung cancer. Diagnosis and therapeutics. And now a lot of the therapeutic stuff that I'm going to show is still kind of research that we're doing, but it is coming. And I think the future of lung cancer is very bright. We may not be doing even robotic surgery. We may just be treating patients with bronchoscopic modalities. So several disclosures. So in the next 30 minutes, I will try to stay on time. I'm going to first talk about the transbronchial diagnostic modalities. I'm going to update everyone on the convex probe EBUS because that is the device that I think is being used the most and what to see in the near future. I'll talk a little bit about guided bronchoscopy. And then in the very end, I'll talk about transbronchial therapeutics. And there's more kind of research component to the therapeutics part. So first, updates on the convex probe EBUS, and everyone in the room here knows that EBUS has really revolutionized the way that we stage patients with lung cancer, as well as how we assess the mediastinum. The sensitivity for lung cancer staging ranges from 85 to 96%, and now it's being adopted in over 3,000 centers around the world. So I think it's a good thing, and there are several companies working on different needles. This is the most, I think, the newest needle. It's called the new VisiShot 2 needle from Olympus. And if you do EBUS, I think you kind of know the difference. The handle is better. It's like a Mercedes versus a Corolla. It's nice and firm. The biggest difference, I think, is the sheath is green color, so you can actually see the sheath on the endoscopic image better. The needle is slightly oval-shaped, so it's more flexible than the previous needle. So if you look at the slide here, this is with the old needle. You can actually flex up a little bit better with this new needle. And I've been using this, and it's actually pretty good. The problem is the price, it's a bit more expensive. And then Olympus also developed a 19-gauge needle. And this, I selectively use this when we need to look at markers, and especially for the PDL1 staining, because cytology specimens are not good for that. It's even more flexible than the 21 or 22 gauge needle, and that's possible because of the laser cuts within the needle. But you can actually get a very nice core. And especially for all the mutation analysis, I think it's good. So that's something that's new. Ultrasound imaging modalities, I think when we do EBUS, we don't really think about this, but there are different ways of imaging on ultrasound, which is being performed in different organs. Harmonic imaging, elastographic imaging, contrast agent imaging. And with the newer Olympus system, the new feature is the elastography, and it just looks at the firmness of the tissue according to the color. So something that's hard would look more bluish, something that's soft would look more reddish, orangish. And if you think that metastatic lymph nodes are in general more hard, this is what it would usually look like. A benign lymph node would look like this, and a malignant lymph node would look like this. So it gives you an additional feature. This is something new that we've been working on. It's still not available, but I think in the next system, we're hoping to have this spectrum analysis, which breaks down the ultrasound image, the transmission, the reflection, the scattering, and it breaks down the image into midband fit, intercept, and slope. And when we use this feature, we can actually predict whether a lymph node has metastatic disease or not. We've been kind of doing many studies on this. It looks very promising. So this is an example of patients that have metastatic disease in the lymph node versus no metastatic disease. And this is probably even better than the other elastography, because elastography is just looking at the stiffness of the lymph node. This is really looking at each cell within the lymph node. So I think this is something that you might see in the near future. What about newer scopes? One of the issue, I think, with the EBA scope is that we are limited to the reach, and most of the upper lobes we cannot insert, and also the N1 nodes we cannot approach with the current EBA scope. So this is a newer thin EBA scope that we've been working on for several years. It's smaller, 1 millimeter smaller, and it's not as big. There is no balloon on this. And with this small head, you can actually go into the upper lobes, the right upper lobe, left upper lobe, the middle lobe, and you have a better reach compared to the previous or the current EBA scope. So I think this will really help in terms of not just the lymph node staging, but a lot of the tumors within the mid-lung area we will be able to sample with this EBA scope. This I haven't shown very much, but this is the next generation EBA scope. It's not the thin EBA scope, but this is what will replace the current EBA scope. So this is the current one, and this is the new EBA scope. The view is a little bit different. The current scope, you're looking at a 35-degree forward oblique view, but the tip is going to be slightly tilted down, so the view is more straight. The head is smaller, and it's a bit more flexible. When you compare the flexibility of the new and the current, you can kind of see the difference. The angle of the needle going in is also different. When you compare the current versus the new or the future EBA scope, it has a more angle. So we think this is going to help with the insertion of the needle into the lymph node. So those are some of the things that hopefully you'll see. And the biggest advantage of this is that station 10R and 4L, usually the most challenging part when you sample will be probably easier with this next generation EBA scope. So I'll talk a little bit about guided bronchoscopy. And when we say guided bronchoscopy, there's different kinds. One is the RadioProbe, ENB, virtual bronchoscopy, and now some literature on cone beam CT and the ultra-thin bronchoscope. I'll go through it. So the RadioProbe EBUS is something that has been available even before the convex probe EBUS. Those of you who have not seen this, it's a very simple device. What you do is you put this probe, which is 1.7 or 2.5 millimeters, into the channel of the flexible bronchoscope, and you can guide it to the periphery of the lung. And when this probe hits the tumor, then you'll see a very well-demarcated tumor on the image. You can use that as a guide to do the biopsy. You can use it together with a guide sheath, where you go in with the guide sheath together with the RadioProbe. Once you find it, you leave the guide sheath in the position, and then you can put your instruments to do multiple sampling. And just as an example, this is an 84-year-old female with emphysema. I was asked by the radiologist to consider doing a biopsy. You can see that the bronchus is kind of very close to the nodule, but it's not in the very easiest place to do a regular biopsy. So these are good cases for the RadioProbe EBUS. So you first start with a flexible bronchoscope. This is the thin bronchoscope that I use. It's a 4 millimeter with a 2 millimeter channel. So you can see you need to really go out in the airway as far as possible. You cannot use a regular adult scope. And then you go in with the RadioProbe and the guide. This is a guide sheath. Basically, you go into the different branches, and once you find this nodule, this is a probe, this is a tumor, You leave the guide sheath in position, then you take the probe out like this. Then you can go in with your forceps and do multiple biopsies. So think about what you can do if you can actually be in the tumor, not just biopsies, but in the future we can maybe deliver different energy, which I will go over in the later part of the talk. So this is doing the biopsy, and this patient was diagnosed with lung cancer, but it was just a diagnosis. But I think the future will be more therapeutics. There are many studies that have been done with the use of the RadioProbe, meta-analysis of 7 studies using RadioProbe for peripheral lesions with a pooled sensitivity 71%, so it's not as good as a CT-guided biopsy, but it is a way of approaching nodules. Electromagnetic navigation bronchoscopy currently in North America. There's the super dimension system and the Varian Medical. I'm not going to go through this because I think everyone in the room knows about this. One is the super dimension system. Basically, you place the patient on the magnetic field, and the bronchoscope and the forceps has a sensor, and you can guide yourself with real-time delivery of information, the electromagnetic waves that's generated on the table, and you basically use the software. So you have to do a CT scan of the patient, you load it onto the system, you plan your procedure, and then do the procedure. The other device is from Varian Medical, the spin system. The difference is that you do not have to have the table. You have an EM field generator on the system. So basically you bring this device close to the patient and then do the procedure. One of the problem is that if you're using, for instance, a cone beam CT, you will not get a good image. So there are kind of goods and bad. And the difference between the Varian and the Super D system is that you put this V pad, which tries to compensate for the breathing, for the inspiration, respiration. So basically you put this pad, you do the CT scan, you use that inspiration and expiration CT scan so that you can actually follow the patient's breathing. So there's less of an error when you use this system. And also there are the tools that they have, including the needle, brush, forceps, has a sensor on the tip, so you can actually see where you are when you're doing the biopsy within the navigation system. So those are some of the difference. But when you look at the results of the studies, they're all not that great. For nodules less than 3 centimeters, 54 to 75%. So the limitation of this is there's always a registration error, and basically it's not a real-time sampling, and it is very expensive. So if you're just using this for diagnostic, it may not pay very well. So I do know that some of the surgeons are using this in combination with surgery treatment. For instance, when you're doing localization for a very small nodule, you can use this together with the VATS and so on. So I think that's kind of the future in how we can incorporate these technologies as a thoracic surgeon. These devices have been used together with the RadioProbe, which makes sense because with the RadioProbe, you can confirm that you are in the lesion. So if you do not know the pathway, you can use the navigation system, reach to the lesion, confirm with the RadioProbe, then do the biopsy. And studies have shown that when you combine the procedure, the yield is higher than each technology itself. So virtual bronchoscopy guidance is also available here in North America. In North America, it's the lung point system from Bronchus. It looks exactly the same, but there's no real-time navigation or electromagnetic navigation. It's just the software. So you have to do a CT scan of the patient, and you load that into a computer, which is very expensive because that's the system. and the computer or the system will generate a roadmap for you. And in this system, you have the real-time bronchoscopic image, and this is the virtual image. Has a software that will recognize the actual real-time image, and it will try to sync together. And I've been using this, but the sync is not, it does work, but it's very slow. So I rarely use it together. I just use the virtual system. I just use it as a map and guide myself whenever I use it. And this is kind of an example of how you can use the virtual bronchoscopy together with a RadioProbe to guide your bronchoscopy. This is a patient who had a left single lung transplant, COPD, and developed a nodule in the right lung. She's on oxygen. The radiologist could not do a CT-guided biopsy because it's high risk, and the nodule is located right there, right here. Very challenging place. So you load the image, and this is actually real time. You set the target, and when you do that and you press the button, it'll generate a roadmap for you. So now you can go in, that's the trachea, that's easy for us. Right side, that's easy for us. And then the middle lobe, that's pretty easy for us. But then you have to go to B5 and B5B, B5 small 2. That becomes a bit of a challenge. So if you don't know the anatomy very well, you can use this. So this is the virtual image. This is a real-time image. So this is in our interventional thoracic surgery suite. I like monitors, so we have many monitors. And using the virtual image, you go out, and this is the tumor that I identified with the RadioProbe. So now I can go in with the biopsy devices to do the biopsy. Unfortunately, this patient was diagnosed with adenocarcinoma, so she underwent SBRT because I don't have the therapeutics ready yet. This is a small study that was done in Japan, not using the lung point system, but using a virtual navigation system, and it's called the V-Ninja study, and they compared virtual bronchoscopy with guide sheet versus EBUS guide sheet alone. They showed that the yield was higher when you use virtual, and a shorter time in the virtual group. So I think it does assist us if you're not sure about the map. This is a meta-analysis of the guided bronchoscopy and looking at the different diagnostic yield. It's still not that good. So I think a combination of devices that you have is probably the way to go. So some of the new things. So CT scan, there have been some reports of using CT scan during bronchoscopy, but you have to be very tall. This is my friend David Feller-Kopman. He's very tall. He's like this tall, so he can do this. But in order for me to do this, I would need like standing still, and it does not work out. And we do not have access to the CT scanner, so it's probably not the very best thing to do. So now we have the cone beam CT, and it's a little bit more flexible. And there have been some group that have been using the cone beam CT as a guide to navigate out and do the diagnosis. But if you wanted to scan the patient, you need a holder to keep that bronchoscope in position. You can see patients intubated, so it becomes a bit more complicated. This is something new that is going to soon come, ultra-thin bronchoscope. This is the lineup of the bronchoscope that are available mainly from Olympus, and for the diagnostic, I usually use these two, and this is the XP190, which is a 3 millimeter, 1.2 millimeter channel, so it's a very small bronchoscope. This is the P190, which is a 4.2 millimeter, so it's like a pediatric scope, but it has a 2 millimeter channel. So you can use all the forceps and the needles and the brush. But we needed something in between, because if the ultra-thin is really good, small, it'll go out into the periphery, but the channel is too small. So the prototype new hybrid ultra-thin bronchoscope, it's 3 millimeter but it has a 1.7 millimeter channel. And 1.7 millimeter is critical because you can still use the RadioProbe EBUS. So with this, the studies have been done, and you can actually reach out into the peripheral nodule better than the current. So this is going to be called, I think, it's called MP190. I think that's going to be the name when it's marketed in North America. I think it'll be coming soon. So in the last 5 minutes, I'm going to go through the transbronchial therapeutics. And there are different ablative technology that are potentially usable in the lung. Radiofrequency ablation, microwave ablation, mainly from new wave, cryoablation. This is the RadioProbe that we use for biopsies, especially for interstitial lung disease, but you can actually use it to freeze the tumor. Some possibilities of using vapor to deliver heat to treat cancer, photodynamic therapy and photothermal therapy. I think these are some of the possibilities. And some of the phase 1 clinical trials that are in development includes the PDT for peripheral lung cancer. This is a study, multi-center study from Pinnacle or Concordia. We're part of the site group of this. So PDT, how many surgeons here have experience using PDT for the central airway? So yeah, a few, I think, but it was mainly used for central type tumors, and I think it was mainly used for palliation of bulky tumors. But the problem is the photosensitivity. But now we're trying to use this for the peripheral nodules. Now that we can reach out into the periphery, why don't we use it in the lung? And it has been shown that it works very well in animal models. So we're doing studies in patients with peripheral lung cancer. Vapor ablation is something that has been developed for LVRS or bronchoscopic LVRS, and now they're trying to apply that for lung cancer treatment. It does work in the animal models. I don't think it has been done in patients yet, but I think the protocol is being developed. And also transbronchial RFA. There has been a few studies here and there, but there's not a very good or a device that's available for RFA. A little bit about nanomedicine is something that I've been working on for the past 10 years using different kinds of nanoparticles. Specifically, I've been using the multimodal liposome. It's called ICG liposome. It's a liposomal agent with ICG and iohexol. So this is a contrast agent which is inside the liposome. So if you inject this into animals, it'll stay in the body for about 3 days. So imagine if you want to do a CT contrast, you have to inject every time, but with this nanoparticle, you do one injection and you can do imaging every time. And also with the EPR effect, this particle will go into the tumor, which is loaded with ICG. So imagine you can do near-infrared imaging. Another nanoparticle is called porphysome. And so using these, how do you use it? So one is the EPR effect, where the nanoparticle gets into the tumor. And this is an example of our animal models using ICG liposome in the tumor. You can see it fluoresces very well. This is just with an IV injection. So you may not have to do local injection anymore. You just do an IV injection a day or two later, or you can go in with a fluorescent scope and actually see the tumor. With the perfimosome, we're developing a way to heat up tumors. With the characteristics of the perfimosome, we can go in with a very low voltage laser and heat up the tumor. So combining the nanoparticle, the injection, going in with the bronchoscope, delivering the energy potentially we can just kill the tumor. So it works in our animal model, and we're hoping to do this in patients in the next 2 years or so. This is an example of how well you can actually heat the tumor up. Some of the other things we're working on is a very novel fiber. This is 0.7 millimeters, which you can put through the flexible bronchoscope, and it has 2 different laser sources as well as fluorescence imaging. So we're trying to use this, develop this for therapeutics. So if somehow we can reach out into the periphery of the nodule better, then you may be able to kind of do more therapeutics. So that's what we're kind of looking at. Also, using laser through the EBA scope, treating lymph nodes and tumors. That's something that we've been kind of working on the animal models. And also more of a personalized medicine where you can actually take samples from patients with EBAs, look at the expression patterns in the tumor, and create a nanoparticle, tailor-made nanoparticle based on what you're getting, and then delivering that into patients. That's something that kind of works in our animal models, but we're hoping that we can use this in patients as well. So to summarize, the new convex probe EBA systems are in development, but not available for clinical use. But I think you saw a glimpse of what's coming, and I think it'll probably expand what surgeons can do, and potentially not just diagnostics. The new techniques in guided bronchoscopy will improve the yield, and for us that may not be important, but when all these therapeutics become available, and when you have not done this, it's going to be too late. So I think as surgeons we should know what's coming and actually use these devices so that you can actually reach out into nodules yourself. Guided bronchoscopy is now an option for patients with peripheral lung nodules, and new transbronchial ablation techniques are in development and can potentially be used for minimally invasive treatment for early stage lung cancer. So this is my members in my lab in our GTX-OR, and a lot of the work has been supported by grants and with collaboration with other members from other labs. So thank you very much.